Yes. So we are live on the YouTube. We are ready to go. Welcome. Good morning, friends. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic, and that is adult ADHD, fact or fad. I mean, ADHD, we know a lot about it in pediatric population. But today we are going to discuss ADHD, that is attention deficit hyperactivity disorder in adults. And for that, we have Dr. Amrita Shah with us. She is a consultant psychiatrist, Vadodara. She did her training at VS Hospital, got her MBBS and MD at VS Hospital, Ahmedabad. She is in private practice for more than a decade now. Her core areas of interest are child and adolescent psychiatry and cognitive behavior therapy. And she is affiliated to several hospitals in Vadodara, including the reputed KGP Children Hospital, where she is serving the children and adolescents too. So welcome to Saturday Club morning meeting, Dr. Amrita. It's over to you now. You can talk for about 40-45 minutes and we'll have 10-15 minutes of interactive sessions. So over to you, Dr. Amrita. Thank you.
Sir. Thank you so much. So thank you so much for having me in this Saturday Club meeting. I'm back again after so many years. The topic which I have chosen is adult ADHD, fact or fad. Now, when I say fad, it is basically the social trend that is going on these days, which I'm coming across on a very frequent basis in my OPD. So that is why I thought of taking up this topic in the first place, because now looking at the increase in rate of diagnosis that is being given in adults of ADHD, I find it a bit skeptical. I was a bit skeptical about this diagnosis, so I went into the detail of the topic and thought of sharing it with everyone. So So this is why I thought of looking into the matter, because recently, almost a month back, I had a patient. She was a 22-year-old female client. She approached my OPD and self-diagnosed ADHD, which is becoming very common these days thanks to the Google and the information available on social media, narrating classical symptoms of ADHD. She was narrating the clinical terminologies which we actually use as professionals, saying that she has ADHD and she needs the clinical approval from my end for the same. But I insisted on a detailed interview. History was suggestive of generalized anxiety disorder in her case. I'm not going into the details of the history, but that was my clinical opinion based on what information she gave. But she kept on insisting for ADHD diagnosis throughout the interview. Her denial for bringing parents for interview was a breakthrough point. I insisted on taking history from the parents because in our field, we mainly rely on the clinical interview, which is taken from the parents and from other collateral sources, especially in such kind of cases. Now, there is a catch in the history. There is some specific point in the history which I'll be coming to in further slides. So this is why I thought of going into the detail of the subject. Let's talk about the facts. I have said fact or fad. So what do we know clinically about adult ADHD, about ADHD and adult ADHD? Let's talk about it. So attention deficit hyperactivity disorder, a very important point is it is a lifespan neurodevelopmental disorder, which indicates that it has to have a childhood onset. So the terminology of adult ADHD is actually a continuum of childhood onset ADHD and not a specific entity which is adult onset ADHD. So lifespan neurodevelopmental disorder, it should have a childhood onset characterized by persistent problems in inattention, excessive motor restlessness, and impulsivity. The last point being significantly interfering with the functioning. When we talk about any of the psychiatric disorders, it is very important that the complaints that the patient is coming with is interfering with their day-to-day functioning, their activities of daily living. Then only we will call it as a clinical disorder. So these are the DSM-5 criteria which we follow for ADHD, which includes mainly two domains, inattention and hyperactivity and impulsivity. So basically, a persistent pattern of inattention and or hyperactivity or impulsivity that interferes with functioning or development, which is characterized by, it can either be inattention, it can be hyperactivity or impulsivity, or it can be both. So inattention, there are a list of symptoms which we go through. out of which 6 or more of the following symptoms should be persistent at least for 6 months. So this is the criteria for calling it as inattention type of ADHD. There is a list of symptoms, and this list of the symptoms, I'm not going into the details of these symptoms, but this is what we refer to when we are diagnosing ADHD in children. Now coming to hyperactivity, again, 6 or more of the symptoms for at least 6 months should be there. Main points are B, C, and D, where several inattentive or hyperactive impulsive symptoms were persistent prior to age 12 years. So this is the age criteria. So I would want to bring to your notice that earlier, before DSM-5, we used to refer to DSM-4-TR. Now we have an upgraded version, that is DSM-5. Earlier, this age criteria was 7 years. It has been increased to 12 years to include more of adolescents and the late childhood onset ADHD. So the criteria is the symptoms should be present prior to age 12 years. Then these symptoms should be affecting their day-to-day activities in 2 or more settings. That is home, school, or work. It might be affecting their interpersonal relationships. And then there is a clear evidence that the symptoms interfere or reduce the ability of social, academic, or occupational functioning. So they should not be because of any other mental disorder. That is, we have to put a differential diagnosis wherever possible. And these are the specifiers. As I mentioned, it can be both inattention and hyperactivity which are present. It can be predominantly inattentive presentation or predominantly hyperactive or impulsive presentation. So these are the specifiers. It can be mild, moderate, or severe based upon the assessment. So what is the progression of ADHD? As we see in the early childhood, that is around up till the age of from 5 to 10 years, the inattention and hyperactivity both can be present parallelly. Matlab, it is not necessarily that it is predominantly inattention or predominantly hyperactive. What we have observed clinically is hyperactivity is more common in early childhood. But as ADHD progresses towards adulthood, the portion of hyperactivity keeps on reducing and it gradually becomes predominantly inattention type. So when it comes to adolescence, this is again a very crucial stage where inattention and impulsivity specifically are seen to be prominent. Impulsivity, why I am saying impulsivity? Because in adolescence, the emotional dysregulation part is seen very prominently, because of which they tend to do things without thinking and indulge into activities like substance abuse at a very early age. Along with that, also self-harming activities, self-harming actions have also been noticed in adolescents with ADHD. That is why impulsivity has been highlighted in adolescence. As it progresses towards adulthood, as I said, it becomes predominantly inattention type and a very vague kind of symptom which is called as emotional lability. Again, the part of emotional dysregulation is seen more prominently in adults. So this is how the progression of ADHD happens with each age. So now talking about the global preference of adult ADHD, see why I'm highlighting these points is because of the recent trends in increase in diagnosis of ADHD in adults. Going through all the clinical studies, it has been found that global prevalence of ADHD in adults is 2.5 to 4% only. ADHD persists in less than 50% of the adults who were treated for same in childhood. Adult ADHD is not a distinct entity. As I said, it is not a distinct entity, but a continuum of childhood disorder. That is why I'm insisting that a history from the childhood onset is very important. Childhood onset of disorder remains the key diagnostic criteria in adults as well. So no such entity as adult onset ADHD is there. So whenever a patient is coming claiming that they have ADHD, we don't have to directly brush off their complaints or brush off their concerns, but we have to be very specific while the clinical interview is being taken. We have to make sure that it has to be taken from various sources to come to a conclusion whether a childhood onset history is established or not. Individual entity of adult onset ADHD is not considered. So there have been, as I mentioned, there have been changes in the diagnostic criteria in DSM-5. The new criteria states that inattentive or hyperactive impulsive symptoms should be evident by age 12 years instead of 7 years. And when we apply these criteria, again, a very important point to be noted, the criteria are exactly the same as in adults as they are in children. Only when I talk about the symptoms over there, in children, it is 6 symptoms out of the entire list. In adults, it is evidence only that 5 rather than 6 symptoms should be present in adults, again leading to overdiagnosis sometimes. So these are the adult correlates of younger individuals and older individuals of inattention and hyperactivity and impulsivity. Again, not going into much details, talking about why a fad, navigating the social media self-diagnosis trend, challenges and diagnosis of adult ADHD. Now, what brings the challenge? What is the challenge when we talk about adult ADHD? There are pitfalls in the diagnostic criteria, failing to distinguish between illness and normal variation. So, as I mentioned, it will be called an illness in adults if they are not able to cope with their day to day living because of the pathology or because of the symptoms. But if they have learned to cope with those symptoms, despite of having a childhood onset ADHD diagnosis, then we would consider it to be a normal variation. Then the diagnostic criteria also don't take consideration of variable course, variable response to treatment. So now talking about the course of ADHD, when a child with ADHD goes into adolescence or and gradually progressing into adulthood, there are chances that the persistence and course features of ADHD might not continue to be there in adolescence. However, there can be a progression towards other kind of disorders like substance use disorders, mood disorders like bipolar mood disorder, or they can have anxiety disorders. So there is an entire spectrum of disorders to which ADHD can progress to. So it is very important to take into consideration that all the clinical studies that have been done in children with ADHD on how that disorder is progressing, there has been always a variable course. There is no constant or consistent pattern that has been seen, and there has always been a variable response to treatment, that is the stimulants that we are giving to the children. So this has to be considered while diagnosing ADHD into adults. Failure to consider differential diagnosis. Sometimes what happens when a patient is so convinced about their symptoms, so we as clinicians also get misdirected by the history. So then what happens is, focusing on the symptoms that has been mentioned by the patient, based on that, we tend to ignore the differential diagnosis. Because when it comes to ADHD, it says attention deficit. Now, attention is a core cognitive function. Inattention is a feature of a lot of psychiatric illnesses. It is not specific to ADHD. So it is very important, coming to the diagnosis of ADHD, we have to consider other domains as well. That is anxiety, depression, substance use disorder, bipolar mood disorder, learning disorders in childhood, and autism spectrum disorder. So all these things have to be considered, and I would suggest that adult ADHD should be a diagnosis of omission. If rest of the things, you are convinced that rest of the diagnoses are not fitting into the patient's list of symptoms, then only we should go for the diagnosis of adult ADHD. Why is it a concern? I will be discussing in the further slides. So what are the other loopholes? Failing to apply the criteria for a childhood onset, as I said, is one of the major problems in diagnosing adult ADHD. One cannot have adult ADHD without first having childhood ADHD. Obtaining collateral information from parents. Now, what has been observed is, see, whatever history has been given retrospectively. For example, if the diagnosis of ADHD was missed in the childhood, and the patient is currently coming to the OPD with the symptoms similar to ADHD, it is a big challenge for us as professionals to retrieve the information about the past, because there will always be a recall bias. So obtaining collateral information from various sources would be needed. Probably checking the school records, going for looking for impairment in school performance as a child. All those kind of details in the history have to be there. So obtaining collateral information from parents, sources of information, how reliable they are, is also another question. As I said, limited recall bias, leading to a misdiagnosis of ADHD in adults. Now, Again, very interesting thing, there are a lot of questionnaires available online. And many of the patients going scrolling through their social media come across these questionnaires, which are very vague kind of questionnaires, not looking into consideration the clinical aspects of other illnesses. Based on those self-report ADHD questionnaires, people are convinced that they have ADHD. So there are chances of high false positive rates. Now we all know that overdiagnosis would always lead to overtreatment. And when it comes to ADHD, the treatment of choice is usually stimulants, and stimulants are tend to be misused by a lot of adults. They are used for recreational purposes. They are very commonly abused by a lot of people, a lot of adults. So it is a matter of concern when it comes to high false positive rates. So self-report ADHD questionnaires, another loophole. There are no structured and specific questionnaires specifically for adults to make a diagnosis of adult ADHD. So here comes the catch. As I said, that 22-year-old female who had come to my clinical OPD with a self-diagnosis of ADHD. Initially, I thought that yes, genuinely she has the symptoms of ADHD, but as the history progressed, retrospectively, the history given by patient was suggestive of anxiety disorder. No matter how much I tried to make her understand, she was not ready to get convinced that she doesn't have ADHD. Now the catch is, this is very interesting. Adults seeking diagnosis deliberately. See, we come across a lot of other patients also who seek diagnosis for depression or anxiety for their own personal reasons, where they are not actually having the symptoms, but just for the sake of some additional advantage that they might be getting at workplace, they are seeking that diagnosis. So when it comes to ADHD, there can be a conscious exaggeration. Conscious exaggeration means they are trying to search for the symptoms, they are trying to look for the symptoms, and then to access the medication. As I said, the stimulants that we are prescribing, they are scheduled medicines and they cannot be given just to any individual. If they are diagnosed with ADHD, then only we can prescribe the medicine. But then otherwise, it is used for leisure purpose, especially in countries outside India. There is a lot of abuse of stimulants. So conscious exaggeration of symptoms to access the medicine. Now, again, interestingly, the case I'm talking about, that girl was studying in UK. Now, and she was not doing good in her exams and she had failed in her semesters. Now, to access to disability accommodations, there are a lot of disability accommodations for students who have ADHD in foreign countries. For example, they are given extra time to cover up their course. They are given extra time in the exams. They are also given writers to write in the exam. So to take access to all these things, also they have a conscious exaggeration of symptoms. So this particular girl I'm talking about, eventually at the end of interview, when I insisted for bringing her parents, she confessed to me that she has not been doing good in her exams. She has not been able to focus in her exams, and that is why she was seeking a diagnosis for ADHD so that she can access some disability accommodations in the university, and she could also explain to her parents that this is the reason why she is not able to do well in her exams. However, it was mainly because of her anxiety issues which she was not able to perform well. But then, because of anxiety issues, she would not be getting any disability accommodations. That is why she made up a history of ADHD. Now, apart from conscious exaggeration, there can also be like subtle motivation. Subtle motivation, as in, for example, I'm struggling through a lot of things in my life where I'm not able to do basic routine activities properly. So I would want to know what is happening to me. So what I would do, looking into the current trend, I would go to the Google. I would try to Google my symptoms and try to procure information from that source. Constantly looking into the information given provided on the social media and Google, I start feeling convinced that yes, I'm having XYZ disorder. And then it goes into my instinctive response that I am having this particular disorder. And then I start attributing my past and future difficulties to that disorder. So, this is the subtle motivation behind seeking a diagnosis. It is not a conscious exaggeration, but somewhere because of constantly having a concern for my own issues, I am attributing things to a particular kind of disorder. So attributing past and future life, you get a reason for whatever wrong is going in your life. So there is a subtle motivation attributing past and future life difficulties to disorder. So this is important because many of the people, many of young population from age group 21 to 25 have been coming up with this diagnosis of ADHD on their own. And see, overdiagnosis is obviously not just lead to over treatment, but it will also give a tag to a person, which would not be right. And in such cases, what happens is, because of such kind of cases, we tend to not provide a diagnosis to genuine cases also sometimes. So we have to make sure that adult ADHD is a very real and impairing disorder. I agree. But adult onset ADHD is not there. Assessing it presents very substantial difficulties, and lot of clinical studies are required, research is required in this particular aspect. Easy to overdiagnose, clinical implications of overdiagnosing leading to overtreatment and stimulants being overprescribed, also giving tags to people, and also leading to not diagnosing those people who might be genuine as well. So lack of effective, efficient tools, and uh, lack of clinical research studies in this particular area is leading to a lot of problem in diagnosis. But overdiagnosis will never help. It is always advised to go for suitable differential, to apply all the differential diagnosis and tools which are needed, and then only come to a conclusion of adult ADHD. Because I have been coming across a lot of patients apart from this particular girl. They are getting reports from psychologists also of adult ADHD, which seems to be very convenient diagnosis, not going for any other differential situations or illnesses. So I would suggest that adult ADHD should be considered as a diagnosis of omission rather than a first diagnosis in whatever the symptoms are. So this is, I tried to keep my presentation as short as possible because this entity is very rare. I wanted to speak about it, and I would welcome the questions. It would be better if we have an interactive session now, because I'll be able to answer and address your queries in a better way.
Yeah, thank you, Dr. Amrita, for
Thank you.
a very brief but very useful presentation.
Yes,
And
thank you.
we as pediatricians are aware about ADHD, but
Yes,
it was good revelation that a lot of adults are approaching you with self-diagnosis of
yes, sir.
ADHD. We do see adolescents these days coming to us with self-diagnosis of depression,
Yes,
anxiety,
sir. So that is
post-stress
also a
disorder, and all
fad
those
in.
things. Yeah, because they read in Google and they make a
Yes,
self-diagnosis. But this
yes,
was a new perspective on
yes,
adult
yes,
ADHD.
yes,
So thank you very much for this. And now you can stop the screen sharing. We
yes,
can
sir.
have questions, comments, because we have a lot of time. I mean, this is one of the shortest
Sir, but
lectures that
I deliberately kept it short because there is n number of information which we can put over here, but I would
right,
want it to be an interactive session.
interactive session.
The reason being, it is not very common, but if anybody has come across this or anybody has a query, I would be able to answer it
Right,
in
right.
one to one.
Agreed, agreed, agreed. So friends, it's over to all of you. Whoever wants to ask question, please raise your hand or put a question in the chat box. I see a lot of pediatricians here, so they might be having some questions.
May I ask one question?
Yes, doctor.
Yes, sure,
Yeah.
Please.
sir. Good morning,
Yeah. Good
sir.
morning. Good morning. How are you?
I'm fine,
A
sir.
good number of times the husbands are being blamed by the wives that you never listen to me.
Ah,
So is there any possibility that good number of husband may be having this ADHD?
no, sir. Don't
Because
think.
we genuinely don't listen. There is no intention not to listen. We may be focusing on some particular time. At that time, we are probably reading an
So
article or
how
listening to
come then
something.
it is ADHD? Because you're having such a good focus on your work that you're not able to get distracted by anything around. So how
Right.
can it be a component of
How many
ADHD?
husbands you have come across where you are diagnosed ADHD?
So, but yes, very interestingly, males are more common to have ADHD as compared
Sorry,
to females.
males
Males
are
are more,
less common.
yes, more
Okay,
common. Males have,
more common.
especially in childhood, the diagnosis and the clinical research says that male children have more chances of having ADHD as compared to female. So yes, ADHD as such, gender-wise, if we see, it is more common in males. But no, I haven't seen any like wife bringing her husband with the complaint of ADHD. I haven't seen that.
Okay, one more question. You
Yes,
just scroll through that particular slide where the number of symptoms are there. Out of you have to
yes,
find out if 5 symptoms are
yes,
positive. Can you
Yes,
put that slide and just
sure, sir.
we have a look at what are the significant symptoms of ADHD?
Yes, sir, definitely, sir. But it was like I thought कि going through and reading each and every symptom might become very monotonous. But yes, definitely we can share it.
Now we have got time, so we can have a
Yes,
look at
yes,
those.
Yes,
sir,
we do
definitely.
have time, and then there are questions in the chat box. We'll take them up once the
Okay.
question is over.
I am trying to share the slideshow. Hmm. So, sir, this is the slide. Can you see this?
Yes, yes, we are able to.
So these are the criteria for inattention. Should I read it or you will go through it?
Please, you can go
You
through
may
it.
read
Yes,
out.
please.
You may read out so that
You
we
will
will.
Okay.
read it, yes.
So, sir, basically 6 or more of the following symptoms should be present at least for 6 months. But if they are very severe, then we can be flexible with this criteria of 6 months. Because if the symptoms are so severe that the child is not, parents are not able to handle the child, then even if it is 4 months, we can consider it to be ADHD. So first, inattention often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or during other activities. They often tend to miss the details in the work or activities that are being given. Then often have difficulty sustaining. अभी it is like कि अगर attention आ भी जाता है तो sustain करने में there is a problem. Attention and concentration. So attention आ गया but sustaining is a problem. Sustaining attention in tasks or play activities is a problem. Then they often do not seem to listen when spoken to directly. Mind seems elsewhere even in the absence of any obvious distraction. Often does not follow through on instructions and fails to finish schoolwork or duties in the workplace. If they are given multiple instructions, they will get lost. They will not be able to, they will definitely tend to miss one or the other instructions, leading to not being able to do the task or finishing the work properly. Again, a problem with organizing, difficulty organizing tasks and activities, difficulty managing sequential tasks, keeping materials and belonging in order. For example, if a child is asked to take out his textbook and write an index in the book along with taking dictation from what ma'am, writing things from what ma'am is saying, the child will feel lost. He will not be able to remember the steps of the task. He will not be able to organize the task into particular steps. Often avoids or dislikes or is reluctant to engage in tasks that require sustained mental effort. For example, homework for older adolescents and adults, preparing reports, completing forms, reviewing lengthy papers. All these things seem to be a big task for them. Often loses things necessary for tasks or activities. For example, a child may forget his bottle, his lunchbox, may keep on losing his pencil, his rubbers on a very frequent basis, losing his books also, school materials in the school, forgetting things. The school materials, pencils, books, etc. is often easily distracted by external stimulus. For older adolescents and adults may include unrelated thoughts as well. So as I said, when it is in children, it is more of hyperactivity and physical activity, but as it progresses into adults, it is mainly the thoughts which their own thoughts which can be distracting as well, not necessarily an external stimulus. Is often forgetful in daily activities. For older adolescents, returning calls, paying bills, keeping appointments, even very important bills they tend to miss. So coming to the hyperactivity, again, 6 symptoms for more than 6 months. If it is very severe, we can be flexible in this criteria. For our older adolescents and adults, as we said, at least 5 symptoms are required. So often fidgets or taps hands or feet or squirms in seat. So fidgety again, I would say is very common in adults in anxiety as well. So, but in children, yes, fidgeting of hands and constantly moving hands, not being able to tip and tiptoeing on the toes while standing, often leaves seat in situations when remaining seated is expected. For example, class. They would get up from their seat. There would be an urge or impulse to get up from the seat and keep on moving around here and there in the class, disturbing the other students in the class. Often runs about or climbs in situations where it is inappropriate. Very interestingly, a lot of children with ADHD, they tend to run on the road, not knowing the consequences, not taking care of the consequences. They would run on the road, and that can be a risk-taking behavior. Jumping from high from sofas or from the places where they might hurt themselves very badly, often unable to play or engage in leisure activities quietly. They need to do something or the other. They are always on the go, acting as if they are driven by a motor, as if there's something inside them which keeps on driving them. And we usually say that they are on Duracell battery. They are never getting tired. It keeps on running here and there, to and fro, unable to be or uncomfortable being still for extended time, especially in public places. See, what happens in public places is kids with ADHD have a lot of sensory issues because naturally they are not able to filter that much of information that is coming from the external environment. So when they are in the public setting, they get too much of sensory stimuli, and that is why they tend to keep on running, and they tend to get it's more of a haywire setting for them because in their mind they cannot organize all those sensory stimulus in a go, and that is why it becomes a problem for them to sit at one place quietly, often talks excessively, blurting out answer, not able to wait for their turn, very difficult to wait for their turn, cannot stand in a long line for a long time, often interrupts or intrudes on others. They can be like, I'm sorry, uh, asking things or answering things without any permission, trying to when two people are talking, they would interrupt into the interaction on their own without, they have a difficulty in reading social cues sometimes. So they tend to do that and interfere with the other or interrupting the other conversations. So these are the criteria based on which we diagnose ADHD in children. And again, except for this five symptoms, the same diagnosis is applied in adults instead. So, sir, these are the criteria, and these are the specifiers.
So, Dr. Amrita, how many, in your practice, how many cases are presented to you which you actually diagnose as true ADHD in adult?
So till now, I haven't come across actual diagnosis of adult ADHD. As I mentioned, there are a lot of loopholes. I mean, I personally don't feel convinced for that diagnosis because there are so many overlapping symptoms with anxiety disorder specifically. As
Right.
I mentioned, that fidgety part, lack of concentration, rumination, all those things are present in anxiety disorder as well. So adult ADHD, adult onset, to not at all,
Yeah,
because
that we have got it.
the source of information from parents is also not so reliable. There is always
Okay.
a recall bias.
So we as pediatricians often wonder what happens to our patients who grow up as adults, no?
Yes, sir.
So the world literature, as you said, is about 1%, 1 to 4%, something like that. So what
2.5 to
exactly happens to them?
2.5 to 4%.
2.5 to 4. So what happens to them as they grow up? Do they become a misfit in the society? Because this kind of behavior we see in a lot of adults, even
Yes,
amongst doctors also we see this kind of behavior.
yes, sir.
The one-
So the prognosis, usually sometimes what happens is adult ADHD patients are more prone to being getting into conduct disorder and
Hmm.
oppositional defiant disorder, leading to antisocial personality
Right.
and indulging into antisocial kind of activities. So
Right.
yes, sir, you are absolutely right that in such kind of adults, there is high risk taking behavior. Substance abuse disorders are very common. Pathological lying, pathological gambling, such kind of disorders are also very common in patients with adult ADHD. So they turn out to be more into the antisocial kind of
Right.
activities and behaviors.
And often they are very mistreated in their childhood because if they are
Yes,
not diagnosed, parents
yes,
don't
sir,
understand them.
absolutely.
That is what
Because of
is
all those lack of diagnosis or lack of understanding in the parents in the childhood, it turns out to be this way.
right. So there is one Dr. Ganesh Kumar from Dr. Ganesh, welcome. He was a very regular attendee to our Saturday Club meetings when it was held physically. He
Yes,
has
sir.
a question here. What is a stimulant and how is it harmful? He is a general practitioner working with
Yes,
railways.
sir. Okay, sir. So stimulants mainly include methylphenidate. Methylphenidate are amphetamines, methamphetamines, not methamphetamines, they are amphetamines. So basically stimulants, as we say, the name suggests that it helps in stimulating the patient, but no, it works on the circuits of the brain where it helps with the inattentive part, mainly in the prefrontal cortex. Prefrontal cortex is responsible for your executive functioning, your organizational skills, and also your personality built up. It also has a control center for impulsivity. So the molecule methylphenidate will work mainly at the prefrontal cortex level and also on a various neurotransmitter circuits to help improve the concentration part. Now, when I say that it is being abused, what happens? It is used for recreational purpose because it improves the concentration like anything. So your ability to focus in a particular thing improves. So in adults, it becomes a habit of using these medicines. Only with the use of these medicines, they can concentrate. Otherwise, they won't be able to concentrate. So that is why it has a recreational and an abuse potential as well. It increases the concentration for a span of good 5 to 6 hours. But after that, there is a fall. So there is again a need to take the stimulant. But
Right.
now, thankfully, there are sustained release medicines available which have a less abuse potential and less potential of being misused because they have a slow onset and sustained response, sustained effect. Otherwise, plain preparations which are available for methylphenidate, they will have a spike of action and then there will be a sudden drop down of the action. So when there is a drop, there is a rebound anxiety or rebound restlessness seen in the patient, because of which they again seek the molecule to have a effect. So that this is methylphenidate is a stimulant that we use, and that is why it is abuse potential and it is being misused by the adults.
Right.
Satish
If
bhai,
adult, if adult
Can I
ADHD,
take the question in the chat box first?
okay, okay,
Uh,
sure.
Sorry. Dr. Seetal Desai from Bangalore, she's a pediatrician. She is asking, does adult autism too need to have childhood onset? If yes, before what age?
See, autism in itself is a neurodevelopmental disorder. So naturally, it has to have a childhood onset. There has to be a history of, autism, so there is very classical history of whatever, delay in the speech, then there are stereotypical movements, then social interaction, lack of eye contact. These are very classical symptoms in autism. So they have to be present in the childhood because it is again a neurodevelopmental disorder. For autism, the age is 6 years. 6 years is the age, this is the criteria. It should be present from 6 years. Before 6 years, we say risk of autism, but
Right.
after 6 years, we can diagnose it to be ASD. So yes, it has to be present in the childhood.
Similarly, for ADHD, what is the cutoff age when we can start stimulants?
Sir, 6 years is in ADHD. Also, for stimulants, it is 6 years, and the symptoms should be present before the age of 12 years, as we have seen in the diagnostic criteria. But the stimulant should be started after 6 years.
Right. So I don't think there are any more questions in the chat box. So anybody who wants to ask questions can go ahead. No,
If-
first. Yes, Dr.
if-
Praveen. Dr.
yeah.
Amrita, can you please stop the screen
Yes,
sharing
sir,
so
I
that
will
we can
stop it.
have, we can see more faces.
Yes.
Thank you.
Yes.
If ADHD remains undiagnosed in childhood and it progresses to adulthood, what are the chances that it may go in for remission, or it will always lead to some sort of a pathological behavior?
So, depending upon mild, moderate, and severe, see, when an adult is coming with symptoms which might be suggestive of ADHD, but there is no history of childhood onset, then sir, the wisest thing is to focus on the present symptoms and treat the symptoms accordingly instead of focusing on the diagnosis of ADHD. And as I said, there is always a differential diagnosis domain which we have to consider. So as you said that the progression part, there are high chances that adults who were undiagnosed as ADHD in the childhood might have anxiety disorders because of poor coping mechanisms, because of low self-esteem, as they know. And as Satish sir also said, that mistreatment in the childhood leading to a lot of low self-esteem issues. They might progress into depression or anxiety. So at that point, we have to treat according to the symptoms that are present, because to be diagnosed with ADHD and then starting the treatment and lack of availability of the information about childhood. So all these things always make us focus on the symptoms rather than the diagnosis and treating the symptoms.
They like in attention group of symptoms. Can you hear me?
Yes, sir, I can
In
hear you.
attention group of symptoms,
Huh.
because in adults you said that inattention is more prominent than hyperactivity.
Yes, yes.
The symptoms are so common and vague that almost no wonder so many
So
people
that is the pitfall.
self-diagnose themselves as
That is the
ADHD.
pitfall. That is
So
what I mentioned.
So how do you attend to those symptoms?
So
How do you address this? Medicines or some other mechanism?
Well, cognitive exercises definitely have to be performed. Like, for
Okay.
example, more of exercises or activities which can help you focus, help you improve your focus. So occupational therapy is something which is available for children in India, but adults who are facing problems with attention, for them also, out of India especially, occupational therapy is something which can help. It is nothing but it includes those kind of activities which involve your persistent and constant attention for a good period of time. So from my end, if I feel that there is a prominent lack of concentration or inattention issues, I would suggest them to engage into more of mental activities or tasks like solving crossword puzzles, going for Sudoku. There are a lot of jigsaw puzzles which are available with more than 300 or 200 pieces. You can try to solve them. So all these are activities or mental tasks which we can give to the patient to help them improve their inattention or concentration issues. Reading can always be a task which can be given to the patient. So out, I would suggest occupational therapy in adults as well, but lack of availability of resources in India, other aspects like what I have suggested can be applied to the patient, which can help them.
What about medicines?
So medicines, yes, we have to give, as I said, symptom wise, we have to treat. If the example of a girl which I had given, the 22-year-old girl, I had suggested anti-anxiety, and it would have definitely helped her because component of anxiety was very prominent in her. So anxiety also leads to lack of concentration and inattention. So if anxiety is remitted, attention span will be improved.
One last question.
Yes, sir.
This ADHD, undiagnosed ADHD progressing into adulthood,
Yes, sir.
is there any data which says that the number of cases who develop dementia in the later life, early dementia in the later life?
So no, no. So I haven't
No.
come across any such data, and whatever material and everything I read, there was no such
So no
mention.
connection directly with
No, sir.
ADHD to
No, sir.
developmental dementia.
No, sir.
Okay, thank you.
Thank you, Dr. Praveen. Now, Dr. Hemant Sant has asked a very interesting question, and that is about, are these groups susceptible to self-harm and suicidal ideation?
Yes, sir. As I mentioned, in adolescence, especially because of a lot of impulsivity, there can be a possibility of going into self-harm like activities, not exactly suicidal ideation, but self-harm. Because ADHD is a condition where there's a lot of energy being piled up. And when that energy is not being channelized into proper sources, then it might come in the form of aggression, it might come in the form of self-harm or harming others as well, indulging into self-harm activities like substance abuse. So all these, yes, it can be a possibility that self-harm behavior can increase
Amrita,
in adolescents
the
especially.
Dr. Satish,
Yes.
yesterday I had a call from my former ICU nurse from HCG, a young man, very hyperactive, and he said that I need help, and he was lonely, and he was said that I'm going to commit suicide.
Hmm.
Actually, yesterday I spent half a day to contact Canada because he didn't say where location from Canada. So
Hmm.
in today's lecture, I thought that it is relevant. What to do when we get such a call, or what to do to help prevent suicide or hurt to such adults?
So ideally, suicidal helpline numbers are available. If such kind of patients need, if you cannot directly contact the patient, at least we can provide those numbers to them where there are lot of on-call help available, where on-call counselings are available.
Madam, I know that. Did you get
Yes,
the
sir.
point? I got a call from Canada without location.
So
As
then
an,
I don't think, sir,
so
I don't
no,
think we
what I
can do
did
much.
is I
Uh,
sent it to a general Canada Twitter that this
uh.
number had called and he needs help and please help him.
So, sir, yes, this is what the best you can do, because if you're not able to locate the patient, how will you be able to help them? If this is the right thing that you did.
And I had to block him from WhatsApp because he was pestering me whole night
Oh
with
my God.
messages. So how
Okay.
do you as psychiatrist deal with it?
So best way, if a patient is accessible to you and you can admit the patient, the right way would be to do that. Otherwise, if you feel that you have provided the necessary information, necessary help to the patient, still he is trying to bother you, then I would say it is better to draw a boundary in such cases, because what the case you are describing may be a case of borderline personality disorder as well, because such patients are very vicious, and they tend to be very intruding many a times with their therapist or their doctors. So, sir, it is right. The right way is to draw a boundary.
Thank
You
you.
did your, yes, yes, you did your part, and after that, we have to set certain boundaries with the patient.
Dr. Ganesh has asked one question. Can wisdom, non-devotion based meditation techniques like TM and Vipassana, etc., be labeled as some type of cognitive behavior therapy?
Cognitive behavior therapy, I would not say, but yes, they can be a kind of therapy. Like meditation is considered to be a kind of therapy, but cognitive behavior therapy is particularly more towards the rational and logical part, and these are more of the spiritual aspects of, I think, therapy, I would say. So, considering that to be a type of CBT, no, but yes, a type of therapy, yes, I can say, okay, meditation in itself is a good therapy, but cognitive behavior therapy is something which it relates to the logical or the reasoning aspect, and working on the thought process through logical and reasoning of your negative thoughts and challenging them and challenging your assumptions. So these are modalities of treatment, yes, but CBT under coming under CBT, I would not say that.
That was interesting question about CBT. I want to ask you one question.
Yes,
As a psychiatrist, no, you
yes,
have
sir.
mentioned in your CV that you have a special interest in
Yes,
CBT.
yes.
How do you manage your time? I mean, psychiatrists usually do not spend time on counseling and therapies. So, are you actually doing CBT or?
That I am doing CBT. See, what I do is that every time a patient is coming to me for follow-up and I feel that they need therapy, so
Right.
what I do is apart from medicines, I do suggest them counselors. But when
Hmm.
they're coming to me, I make sure that there has to be a session where the cognitive CBT part is applied to them, so that apart from the therapy sessions that they're taking, whatever the therapist is applying to them, they are also getting an additional benefit of CBT from my end, because
That's great.
CBT does help a lot of patients with neurosis, that is depression and anxiety, especially young female patients who are coming to me. CBT is doing very like wonders for them. So a low dose of medicine with CBT can give very good results in such kind of cases. So sir, I manage my appointments in such a way that if there is a patient of CBT, I give that much of time to them so that
Yes.
they are also satisfied. I also feel satisfied that I have done my part by helping them through CBT.
That's very great because there is always one grudge against psychiatrists that they
And
themselves do not do any therapy. So
yes,
it's
yes.
very heartening to know that you are yourself
So
giving a
in fact,
session.
lot of like now, the young psychiatrists, lot of them
Okay.
are trying to practice CBT. There is rational emotive behavior therapy, dialectical behavior therapy. So they are, lot of them are applying these things now.
I am a practitioner and teacher of REBT. So
Oh, great, sir. That is great.
I do it for adolescents and young
Hmm,
adults.
very nice. Very
So
nice.
very happy to know that you are doing the
Yes.
same. And
Thank you, sir.
yes.
10
So
minutes are
anyone-
left. So can I ask one not related to the topic question?
Yes,
yes,
sir.
yes. We have
Yeah.
5 minutes time
Yeah.
still.
So a good number of our patients, old people, they don't get sleep and they are happy with taking one small tablet of clonazepam or alprazolam and then they sleep well.
Yes, sir.
Uh, Normally, the psychiatrist said that these all anti-anxiety medicines should not be continued beyond 15 days because they've got a potential for being
Hmm.
abused and habit forming.
Yes,
So
sir.
is it okay to continue with one tablet because they will take it otherwise also, even if you give them
Yes,
or
sir.
not? So they will continue to take
Yes.
it from this way or that way. And if they continue, is it harmful? If we want to discontinue, how can we
Huh.
encourage them to stop it? Because they said that कि 2 दिन हमें नींद नहीं आएगी, फिर 3 दिन
Hmm.
नींद नहीं आएगी. So
Hmm.
is there any way that we can put them to sleep without taking the tablets?
So
Sleep
if the
hygiene, I know, and
medicine,
we have told them, but that doesn't help.
which one, sir? Sleep hygiene.
Sleep hygiene,
Uh-huh. Sleep hygiene in old age,
but
sir.
they keep awake with sleep
Yes,
hygiene.
yes. It doesn't help much because it is more of a biological thing with age. Rather
Yes.
than on a thought level, it is more of a biological thing with age. So, sir, yeah, as far as your question is concerned, sir, I would always suggest that we should go for risk-benefit ratio. If one medicine taken regularly is helping to improve a quality of life, there is no harm in taking it. But we have to make sure that one is not converted into two or three. If we see that the patient is developing tolerance with one tablet and they are not able to sleep well on that, then we can suggest to move to some safer molecules like zolpidem, or including melatonin, adding on to melatonin or something which would not be habit forming and which can also assist in the action of the medicine that they are already taking. So it is always good to go for a regular follow-up and try to assess for development of tolerance in such kind of cases. If the tolerance is being developed, then instead of increasing the dose of benzodiazepines, I would suggest to introduce melatonin, which is also helpful in old age because there is a shift of circadian rhythm in old age and late onset of the sleep, leading to the entire body clock being disturbed. So adding melatonin along with a low dose of benzodiazepine can also be helpful. But a regular monitoring is needed and risk-benefit ratio has to be seen. Long-term use of benzodiazepines leads to cognitive dullness, and that is why also we have to be very observant of the amount of dose that we are giving to patients in old age.
Amrita,
Yes, sir.
glycine containing, serine containing amino acids,
Yes,
food,
sir.
like
Yes.
bananas and hot milk, they add to the sleep mechanism.
Yes, yes, sir.
And
Yes,
other
sir.
therapies, like what other people said, like whatever meditation in any form, or most important is some of the music ragas.
Sleep
They have
meditation. Yes, sir.
yes,
Yes, sir. Yes,
Pilu
sir.
and lot of ragas are there.
Yes,
But
sir.
if the patient is anxious and the cause is not removed, the
Huh.
person will not sleep.
Not sleep. Yes, sir. Agree. Yes.
What are the chances? I am really obsessed with dementia. What are the chances of these people who are taking one tablet of developing early dementia? This is
Sir, early dementia,
benzodiazepine.
nahi, but as I said, cognitive dullness, yes. Long-term use of benzodiazepines can lead to cognitive dullness. Dementia is will be
Even one tablet of that, some sort of a tablet will cause
so
dementia.
risk is there. I would not say
Risk
they
is
won't,
there.
but the risk of cognitive dullness is definitely there with long-term use of benzodiazepines.
Because with these people, problem of going to sleep is not there. So melatonin probably may not help with them because their problem is interrupted sleep.
So
So
then zolpidem.
zolpidem
Yes,
probably.
sir. Maintenance to
And
zolpidem. Yes, sir.
is zolpidem safe?
Sir, I have seen old age patients getting dependent on zolpidem as well. So now I cannot claim that it is safe, but it is relatively safer than benzodiazepines.
Okay. Thank
So,
you.
Yes.
thank you all participants for very interactive session. And of course, thank you, Dr. Amrita.
Thank you, sir.
It was wonderful because you made the topic very simple and you didn't go much into theoretical aspects and talked more about practical aspects.
Yes, sir.
And I think that opens up an avenue for many more such talks in future in Saturday Club. As you must have seen that people have a lot of questions regarding these mental health issues in their patients. So we'll invite you again sometime later for another
Sure,
such
sir,
session.
definitely.
So thank you very much for joining with us. And thank you all for joining. We meet next Saturday again. Thank you all. We end the session here. Thank you.